Now we'll move on to talk about drugs that treat thyroid disorders. Our first group is used to treat patients with hyperthyroidism. These include propylthiouracil, or PTU, and methimazole. It is really important to know how these drugs work, and it goes back to our discussion on thyroid hormone synthesis. Both drugs block thyroid peroxidase. We talked about thyroid peroxidase in our physiology lecture. Can you tell me what are the two functions of thyroid peroxidase? So one, it catalyzes organification of iodine so that it can be attached to tyrosine residues on thyroglobulin, and also it couples the thyroid hormone precursors MIT and DIT to form T3 and T4. PTU also decreases peripheral conversion of T4 to the more active form T3, and it does this by blocking 5' deiodinase. Adverse effects of both drugs include skin rash, agranulocytosis, meaning a low neutrophil count, and aplastic anemia, where you have a drop in red blood cells, platelets, and white blood cells. Here's a hint for you on how you will be tested on the side effects of agranulocytosis. You'll be presented with a patient who has a fever and sore throat or some other infection after starting one of these drugs. They may give you a list of drugs and ask you to identify which one caused these symptoms. And perhaps they'll even ask you what the next step in management of this patient is. Well, you should definitely suspect one of these two drugs, and in addition you will want to stop it and consider starting a granulocyte colony stimulating factor type of drug. Also remember that methimazole has potential teratogenic effects and therefore should not be used within the first trimester of pregnancy. Rather, PTU is the drug of choice here. However, after the first trimester of pregnancy, PTU is then switched to methimazole for the next 2 trimesters. Now, even though PTU is used in pregnancy, it is not a benign drug. In fact, it has been found to cause hepatotoxicity in some cases, and should only be used in rare circumstances such as life-threatening thyrotoxicosis or thyroid storm, and when methimazole, surgery, and radiation treatment are contraindicated. Okay, time for another flash quiz. A patient with a history of hyperthyroidism but non-compliance with medications comes to the ED presenting with tachycardia, palpitations, tremors, and anxiety. What is the first-line therapy in this case? Propranolol is the answer here. It is a non-selective beta blocker which can help with tachycardia and palpitations. Additionally, this drug has the added benefit of decreasing conversion of T4 and T3. Of note, many patients presenting with thyroid storm will also be treated with methimazole or PTU in addition to iodine. Another thing to note is for patients who will undergo thyroidectomy, often iodine is administered prior to surgery. Do you know what the reason for this is? Well, it turns out that iodine can help decrease gland vascularity, thus making removal much easier. Moving on to the treatment of hypothyroidism, we have 2 drugs to remember. Levothyroxine and triiodothyronine are synthetic versions of thyroid hormone. Specifically, levothyroxine is T4 and triiodothyronine is T3. Do you remember which one is the active form of the hormone? Right, T3. Now, since these drugs are used to replace thyroid hormone, which is not being made, name 4 side effects you might expect to see. Think about the side effects as symptoms of hyperthyroidism, and these would be tachycardia, heat intolerance, tremors, and arrhythmias. On the boards, if you see hyperthyroidism symptoms and no apparent cause, keep in mind some patients may be taking these drugs surreptitiously or inadvertently in diet pills. Let's talk about a few drugs that are related to the hypothalamic pituitary axis. The first is growth hormone, which can be given to patients with short stature due to growth hormone deficiency or Turner syndrome. Do you remember what karyotype is associated with Turner syndrome? Right, XO. Next we have octreotide. Octreotide is a somatostatin analog that is useful in acromegaly, carcinoid, gastrinoma, glucagonoma, and esophageal varices. Furthermore, carcinoid tumors express lots of somatostatin receptors, and therefore can be inhibited using a somatostatin analog. The use of octreotide for the treatment of esophageal varices is via its effect on decreasing splanchnic blood flow, and splanchnic refers to gastric, small intestinal, colonic, pancreatic, hepatic, and splenic circulations. Oxytocin, which you'll hear about more in the reproductive lectures, is an analog of the hormone itself, so it is no surprise that it stimulates uterine contractions and can be helpful in both inducing labor as well as controlling uterine bleeding. Additionally, it is the stimulus for milk letdown. Next we have synthetic ADH or desmopressin, also known as DDAVP, which can be given for diabetes insipidus. So as you can see written here, it is used for central and not nephrogenic diabetes insipidus. Do you know what the reason behind this is? Well, it's because in central diabetes insipidus you have decreased production of ADH, whereas in nephrogenic diabetes insipidus you have impaired renal response. Demococycline is one of the tetracycline antibiotics, but a known side effect of this drug is that it blocks ADH. That's why it can be used to treat SIADH. But what do you think the side effect of this is going to be? Right, it will induce diabetes insipidus. In this case, nephrogenic diabetes insipidus, because it blocks the kidney's ability to respond to ADH. Since it is a member of the tetracycline family, it is also associated with photosensitivity, bone, and teeth abnormalities. There are many different glucocorticoids, such as hydrocortisone and prednisone. How do they work? Well, their mechanism of action is to inhibit phospholipase A2, which decreases the production of leukotrienes and prostaglandins. They also decrease the expression of COX-2 to further block the synthesis of prostaglandins. Because they suppress the immune system, they are used to treat a variety of autoimmune diseases, such as Addison's disease and lupus. Also, they are used to treat conditions such as inflammatory bowel disease and asthma, in addition to a whole slew of other inflammatory and oncologic conditions. The major side effects of long-term glucocorticoid use is an iatrogenic Cushing syndrome, and you should be very familiar with the associated symptoms of Cushing syndrome as we reviewed in the pathology section. Let's say you have a patient on long-term steroids, and the patient suddenly stops taking their medications. What could be one serious side effect of this? Good, adrenal insufficiency. If you recall, steroids like cortisol will inhibit the release of ACTH from the anterior pituitary. And over time, since ACTH is a major stimulus for the growth of the adrenal gland, we'll see atrophy of the adrenal glands. Thus, if the drug is suddenly stopped, the adrenals will be unable to respond sufficiently, and patients can die from shock. Now let's do a couple of questions to review this topic. Our first question is about a 55-year-old man who presents to the ED with complaints of episodic diarrhea, spells of difficulty breathing, and periodic flushing. An imaging study reveals multiple nodules in the liver. Urine analysis shows a normal vanillyl mandelic acid level, but a markedly elevated level of 5-hydroxyindoleacetic acid. The administration of which of the following pharmacologic agents can alleviate this patient's symptoms? A. Bromocriptine, B. Carboplatin, C. Octreotide, D. Spironolactone, or E. Prednisone. The answer is C. Octreotide. The reason is as follows. The patient presents with typical symptoms of carcinoid syndrome: recurrent diarrhea, cutaneous flushing, asthmatic wheezing, and right-sided heart failure are all symptoms we should be looking out for. A somatostatin analog, such as octreotide, has been shown to alleviate symptoms caused by excess serotonin. Remember, this drug can also be used to treat acromegaly, insulinomas, and diarrhea secondary to VIPoma. Our next question is about a 42-year-old woman diagnosed with type 2 diabetes mellitus and begins monotherapy. After 6 months, her physician decides to add rosiglitazone to her regimen. Which of the following is the mechanism of action of rosiglitazone? Does it A. increase proinsulin cleavage, B. B. Increase tyrosine kinase activity. C. Modulate peroxisome proliferator activated receptors. D. Prevent absorption of glucose in the intestinal wall. Or E. Trigger release of insulin. The answer again is C. Thiazolidinediones are oral hypoglycemics that increase peripheral sensitization to insulin by binding to and modulating the activity of transcription factors called peroxisome proliferator activated receptors. They also decrease hepatic gluconeogenesis. The answer D describes the mechanism of acarbose, an alpha-glucosidase inhibitor, and answer E describes the mechanism of action of sulfonylureas. Alright, you made it through the endocrinology lectures. Congratulations. You've worked hard. Now it's important to be sure that you're getting good sleep and eating healthy, so your body and mind will be ready to take this test. Keep up the great work.